just a little bit early. We are on our second presentation for our outpatient track. We have Dr. Sarah Sutton and Dr. Katherine Ritter. Dr. Ritter is an MD trained in family medicine. She practiced in a rural primary care for 3 years and then shifted into urgent care 7 years ago. She has been an antimicrobial stewardship champion for the past 2 years, ever since she realized there were others who shared their passion for changing the culture surrounding antibiotic prescribing. Being an active participant in stewardship efforts allow her to channel her creative talents into comedy skits and original songs, which I hope will be included in the presentation, which have encouraged her immediate care peers to feel empowered when engaging in difficult conversations with antibiotic seekers. And we also have Dr. Sarah Sutton, who was trained in Med-Peds and Med-Peds infectious diseases. She has participated in antimicrobial stewardship at Inpatient Northwestern Memorial Hospital since 2002 and has been the medical director of Northwestern Antimicrobial and Diagnostic Stewardship for the past 14 years. One of the aspects of stewardship that she values most is working collaboratively with persons of many backgrounds and talents. By participating in the IDPH-sponsored grant since 2023, she's leaped into the outpatient realm, and the goal is to reduce antibiotic selection pressure throughout the continuum of care. So welcome them both on the Secret Agents of Stewardship.
Thank you. Great. Well, I've been introduced. Thank you. I'm Sarah Sutton, and I'm at Northwestern. I've been there for about 22 years. I'm the medical director of antimicrobial stewardship, but it really is has been inside the hospital. I haven't really branched out until a couple years ago. So it's been really exciting to jump into this other realm. I'm here to talk about a big problem, the problem of antimicrobial stewardship in the outpatient setting, because it's such a diverse, heterogeneous area. It's not controlled like the inpatient setting is. I can't say, oh, this attending does hem-onc. I understand the field that they're in. I just don't have control over it. And there's so many different kinds of settings, right? There's immediate care, where we've been focused on in part at the beginning of our grant. And then there's the hem-onc clinic that's triaging neutropenic fever. Okay, wide disparate patient populations. So here's the setting. Antimicrobial stewardship was really born in the hospital, and it's matured in the hospital. But and that is the source of where our fundings come from. Unfortunately, outpatient stewardship has kind of extended from our experiences in the inpatient setting, but it didn't come with automatic funding, right? And now we have a mandate. We have a mandate to do outpatient stewardship, but we don't have the funding. We don't have the infrastructure. We don't really have the culture in all of these settings, right? So we're starting kind of at ground zero in a lot of instances, or at least there's a continuum. Some people have it in this little niche, but next door, there'll be clinicians who have no knowledge about stewardship. It's really challenging. So the problem, on January 1st, 2020, the Joint Commission made the outpatient standard. But this caught US healthcare by surprise. And the next thing you know, a couple months later, we had another surprise, and that was COVID. But in the aftermath of COVID, Northwestern Medicine certainly was caught by surprise about this mandate. Northwestern Medicine is 11 hospitals and over 200 outpatient settings. Our grant really didn't approximate trying to revolutionize outpatient care and in the model of good stewardly behavior at all. We started off small, but still it was really, really daunting without that funding, without the infrastructure, without the culture. So how do we start? Dr. Donati's already talked about how it took us a long time to kind of get the nuts and bolts settled of stewardship, the guidelines, the posters, the pamphlets, people in line with what our goals were from leadership to choosing our champions. It's been a big project. But the kind of nuts and bolts didn't really bring our project to life until we started thinking about who's going to carry on this project after we're gone? And who's going to really bring a project to life where there's that action that needs to happen, a problem identified, an action, a purpose, a goal, a campaign that has to happen. And then you have to measure change after a project is instituted. Who's going to do that work? Who's going to choose the goal? Who's going to know what's going to work in developing a project? So these were big questions, and we were a little bit at a loss. So stewardship and the field of behavioral change, which are kind of neighbors of each other, have acknowledged the idea of that peer champion, right? That if there's a champion, you're much more likely to be able to get a project to come to fruition, going to be able to get it to work. But what if there's no obvious candidate to be a champion? What if the culture hasn't really prioritized stewardship ever before? Nobody's really passionate about it. Nobody's interested in it. What if competing values from leadership really leave stewardship in the dust? These were some of the things that we broached as we dealt with 3 different kinds of programs. One was the immediate care centers, which were doing rapid fire, non-continuity care, and then 2 FQHCs, public health centers, right? We're in the neighborhoods and dealing with whoever comes, whatever their population is, but often didn't have the capacity to see a lot of acute care visits. So they were kind of starting from ground zero. So here's our idea, that we would pilot a workshop of group education for these stewardship champions. We would invite willing, smart, enthusiastic, passionate clinicians, prescribers, to come with whatever stewardship knowledge they had and join with us, align with us, partner with us, and see what happened. It was really an uncharted course at the beginning. And the idea was that wonderful idea of sustainability, right? Somehow, with our leadership and our guidance early on, it might be a little heavy, will gradually decrease, and the champions will be able to hold their own and lead the charge in stewardship and behavioral change. Well, that was our idea. So I don't have any disclosures. So part 1 of our objectives is to describe a model of stewardship champion group training. And this will be part of that elusive implementation packet that we're going to be ultimately delivering. Identify some available resources for stewardship champion training that already exist, that are available, and resources that are readily available to anyone. And then recognize the boundless potential roles of a stewardship champion in the outpatient healthcare setting. Really see how they can blossom with their own talents and bring that to the table and make it their own program. Part 2 will be to appreciate some lessons learned from a stellar outpatient champion, Kathy Ritter, who's my partner in this talk. So this is actually kind of a loose timeline that we've created. And Dr. Donani already spoke about how this standard came out. There was realization that there was an implementation gap, and there's some healthcare disparities. And the money drifted to IDPH, and then they gave us the grant. And so our first step when the grant was delivered to us was we had to form a team. I'm going to kind of go through the steps that we went through, so maybe you can learn what we went through. The first was just getting a team together. We identified that IDPH had a stewardship team that was going to be involved, and Jamie Jacobs was our lead, and she has really been helpful all the way through our project. We had representatives from ADSP, including our pharmacists to advise us on correct dosing and guidelines, and Mohammed Danani and I. We had an expert in how to do surveys actually on stewardship. And that was Dr. Evans of Hines VA. We had a project manager, Deja. We had then 3 clinical settings. We had some portion of the immediate care facilities throughout Northwestern medicine, which really goes from inner city Chicago to the outer reaches of Fox Valley, I think, right? And we had 2 community partners who have been aligned with Northwestern all the way along, but they are two federally funded health centers. So in the planning stages, we decided that we would then, at the top of my slide there, that we would have a team of champions. We would form it, and we would come up with a project and get people together and find out how to attack stewardship in the outpatient setting. Because, to be honest, none of us in NMH stewardship knew much about outpatient stewardship. So there was an implementation gap on the part of our leadership. So then we had to decide, well, so what are we going to do with this team of champions? We said, well, who is it going to be? 1 champion from each outpatient healthcare setting. And that turned out to be 3. Actually, in the beginning, we thought it might be many. It might be 1 champion from each site, so there'd be a local presence. And we got a defined no from our leadership, from the leadership at the level of the ICCs. They said, you know, maybe 1 or 2, okay? And so we had to adjust. It was that partnership that happened with the corporate suite that has other priorities, right? They're thinking about keeping the lights on, right? So they've got other priorities. So it came down to we were going to have 1 or 2, and that turned into 1 for all the immediate care centers. And then we had 1 from each of our 2 FQHCs. We had 1 stewardship leader, and that was me. And as I said, you know, I didn't have a lot of outpatient experience. I had my own clinic. That's not much, right? Okay. When we decided that we'd meet once a month, and that would be on a virtual platform because we were in different geographic places. That was a gift from COVID. We were all familiar with being on a virtual platform. The program began just this spring. We've had 5 monthly meetings since then, and we're planning on continuing about a year or so, and maybe it'll live on beyond our grant period as well. And what will this team of champions be? Early on, we were thinking, well, we're going to have paid administrative time for champion work. And that is a gift from the core elements. The CDC said we've got to have financial backing for stewardship work. People don't work for free, and passion will come if you're funded, right? When you have the time and you can really work with something. If you're going to be squeezing it into your nighttime hours of between 9 and 11 at night, stewardship isn't going to happen. It's not going to flourish. I know that. I've done it. At any rate, so paid administrative work. We were blessed with a grant. And so we had some money to give to these places as seed money to pay for their champions. It was wonderful. Each meeting has to have time set aside for stewardship, fellowship, and sharing. From the beginning, we thought that this was really, really important to be able to share and share the problems and the struggles and successes, and also the insights that came from the disparate settings that of healthcare that we were dealing with. The differences made it a much more lively discussion. The similarities also made it an important time to just share the frustrations of dealing with people who are used to getting antibiotics every time they come to the doctor. We recognized that it was going to be a differential learning environment. This comes from pedagogy, right? That this is going to be like the one-room schoolhouse again, right? Where you have the first graders learning from the third graders and the fourth graders. There's going to be a continuum of an understanding of stewardship principles and action and behavior, and basically different ways of interacting with difficult personalities, right? And I think just recognizing that there's going to be strength because it is a one-room schoolhouse, to be imprecise, is really, it made it fun. And we could be encouraged when people shared what they were experiencing, and that made it really an exciting environment to be part of. Our goal was to really educate the stewards so that everybody kind of reached the same level of understanding about stewardship, and for each person to feel empowered. And finally, our ultimate goal is for each individual with a little bit of help and some data to identify a stewardship campaign and kind of carry that campaign into action. And that's at the beginning stages. Here we are at 5 or 6 months into the program. So it takes a lot of time. We then had to think about recruiting. This wasn't too hard, actually. One of the champions is a good friend of mine from 25 years ago. That one was easy. Kathy Ritter, our co-speaker, was already interested and invested in acting as a champion, so she was a natural. And we had one of our FQHCs had somebody who had been doing in the stewardship environment at her place of work. So stepping back, though, we thought, well, we should at least put down on paper what is necessary to be a champion. On my little list, there's not extensive knowledge about antibiotics, right? It's not having a PharmD after an MD's name, right? It doesn't need that. It needs somebody who has who is in the setting, who works in the setting a lot, who is working every day kind of in the trenches of the healthcare setting. And that person would know the pressures that are coming down from on high and coming from the patients, coming from the evaluations on about patient satisfaction. That person also would have that paid administrative time. The champion needs to have, I don't know, a little bit of expansive personality, somebody who can get out there and likes to lead, likes to teach, likes to be an example, likes to strut around a little bit, I think. I think they need to be intrigued by the process of behavioral change. I know that's what attracted me to stewardship in the beginning was, and it still does. It's like, can we move this mountain of a culture of fixed ideas about how to treat sinusitis? Can we move it an inch? Can we move it 2 inches, right? And one has to, I think, on the list, be willing to take risks. There's a lot of failure in stewardship. You can do a whole lot of work and not measure the right thing in the right way to really get a change in your data. But you also have to realize that we're working toward a change in behavior, like I like to say, between 2 ears. Somewhere in here, right? We have to change each individual prescriber to be, when they're at that moment with their electronic prescription pad, to say, no, I really shouldn't do this. Let me attack this in a different way. Let me talk to the patient again. Let me think about those the guidelines, right? Or let me think about the duration. Think about the right drug. So we then developed educational milestones, and wonderful. We had a recipe for that, and it was in the core elements of outpatient stewardship. So basically, we took each one of those concepts: commitment, education with expertise, action, and tracking and reporting. And we said, well, what's necessary to fill that out? What should the champion be doing ultimately on their own with a little bit of help from us? What should they be doing by the end of all this? So that's where medical education is all gone into, right? We're all into milestones. It's like, it's not how fast you get there. And it's not that you have to know this by day 1 or 6 months into your internship, but do you know it by the end? And are you able to be an example? Same thing with this stuff. Adult Education 101, milestones, right? Okay. So what have I done? Oops, uh-oh. I've yellowed some of the milestones that we've already achieved. Basically, kind of 3 out of 3 of our champions have already reached them. So we got buy-in, so that because of our grant, we were able to get buy-in from the administrators that yes, they had administrative time. That was really a good one. That one isn't going to be guaranteed across the board. We got maybe not 100% participation, but a lot of our champions being able to communicate with administrative staff and use a clear, concise stewardship message, that kind of elevator speech that Dr. Donani spoke about. In terms of education and expertise, the people in the champions know that they're going to be able to reach out to anybody in NMH stewardship, our pharmacists or the MD faculty to get some expert advice. And they've communicated with us, particularly about antibiotic availability in different neighborhoods and regions throughout the greater Chicago area. That was really important. We weren't serving them well when we gave them antibiotics that couldn't be filled at their local pharmacies. Another really significant part about education and expertise was that there'd be some communication skills training. And I'll be going into that a little bit in the rest of the talk. In terms of action for policy and practice, we've had a lag time in developing the data that allows the FQHCs to choose a campaign, but they're working on it. They're working on it because they're in the trenches and they know what's going on with their populace, the people that they serve. But that takes a while to develop, and I think the CHARMS program is going to potentially take over the state of Illinois and help with that problem. Once again, back to communication strategies, ultimately, people need to learn the communication strategies. The champions need to learn them. They need to practice them. And then they need to be able to teach them to others, okay? And that takes a while. It takes a while to be an expert enough to be able to teach. So we're working on that. And I think Kathy Ritter, our champion at the ICCs, already has that down pat, because every time she does a skit, she's talking and communicating about strategies about how to get the message across to leadership or to patients about good antibiotic usage. I do want to say that that because there's a lag in getting the data, the tracking and reporting is the thing that's slowed us down a bit, and being able to give provider data back is the thing that's lagging us behind. It's going to take a little bit more time before we get report cards to be able to say, you know, you're using too much of this drug, or your duration is off, or you could be using less fluoroquinolone, that kind of thing. So what if peer champions prove to be that secret ingredient for behavioral change in the outpatient setting? Will a group of stewardship champions formed from disparate healthcare delivery systems form a cohesive, effective team to promote stewardship at each site? Will they provide insider insights? Will they identify healthcare disparities? These were our goals. What unique talents will each champion bring to outpatient stewardship? I have this picture up here of superheroes, right? Remember, each superhero in all the superhero movies you've seen, you know, one is very muscular, the Hulk, right? And he's green, right? But nobody else is green. Nobody else is that bulked up. Somebody else like throws his shield around, that's Captain America. Each champion's going to bring their own skills. And that's why I kind of like the idea of superheroes. And another thing, at what level should champion work, should the champion really work and act at to promote a culture of change? We thought about that a little bit. Really, we need a champion to be working at three different foci, right? They need to be able to talk to leadership correctly, effectively. They need to be talking to their peers, prescribers, and they need to be talking to patients and their families, or strategizing for work with patients and their families. So just getting into the curriculum a little bit, when we do communicate with leadership, how do we do it, right? So I had the big idea, well, you can write emails and you can set up formal meetings, but those people are really, really busy, aren't they? They've got priorities I can't even think of, right? So the team of champions came up with some really good insights. They told me, they taught us, right, to use chance downtime interactions to reinforce stewardship messages. It might be in the elevator. It might be when they're sharing the same workroom, okay? It might be in the women's bathroom, right? And the other thing that they provided for me was the insight to really use each of those interactions, formal or not, to remind leadership that supporting an active stewardship program is a requirement for the Joint Commission standard. That was really, really helpful. Just plow it in every time you see them, okay? Don't let them forget. I love that. What else about communication skills training? This is evidence-based stuff. Word choice matters when you're talking with patients. Explain why antibiotics won't help. This is that negative message. Antibiotics aren't going to help you because this is a nasty cold, so antibiotics won't help and won't get you better faster. The strep test is negative, meaning your sore throat is caused by a virus and antibiotics won't help. You're catching the phrase there, and antibiotics won't help, right? One of the things, patients are less likely to expect antibiotics for a chest cold than bronchitis. So word choice matters. Fascinating, evidence-based. What about other data about all those interactions, those thousands of recordings of patient interactions, when it worked and when it didn't? What does the data show? What physicians need to do, healthcare workers, prescribers need to do, is focus on the negative aspects of unnecessary antibiotics that impact the individual in front of you, not the world, not populations, okay? Antibiotics can cause diarrhea and belly pain and ruin your week, ruin your vacation, right? You don't want to do that. And avoid the messages that we in this room all love, right? Each antibiotic-resistant infection costs up to $30,000 to treat than other infections. Antibiotic-resistant bacteria cause over 2 million illnesses and 23,000 deaths in the US each year. We love that. We thrive on that. Patients don't. That's what the data shows. So what else about communication with patients? It's all in the literature. Really begin with empathy. We were able to extract models for communicating. And one of them is the SMART strategy that's embedded in the IDSA core curriculum for antibiotic stewardship. And also the DART strategy. So Stanford made SMART and DART was made at University of Washington. And the DART strategy is all online. If you just remember DART, you can Google it. The team of champions gave some insights, and that is that they really need to practice the role playing in order to reinforce the practice of communicating well. So to summarize kind of the DART strategy and the SMART strategy, really start with empathy and do that focused history and exam, declare a diagnosis. You have a cold or a head cold or a chest cold, and then a negative and positive treatment recommendation in that order. That order is really important. First, that negative. Antibiotics aren't going to help you get better faster and might hurt you. And then the positive, but I have some tools to make you feel more comfortable, okay? But back to that first thing, start with empathy. Boy, it sounds like you've been miserable for 4 days. I really feel for you, okay? And then finally, the roadmap and contingency plan. Most, but not all sinus colds start to feel better by 7 to 10 days. But if it doesn't, what can you do? So I've summarized just for on your flash drive some other curriculum resources that I've found helpful, and they really are plentiful. Not all of them are evidence-based that they actually work, but and some of them are fun and lively, and so but I think it's good to have some resources listed down, and in our implementation packet we'll have some more of those. So I wanted to just tell you, what am I doing on time? Not much. Okay. That from Team of Champions have come some really evident or ideas about healthcare disparities. One of the things is that that the way payment happens from a visit can vary from one healthcare setting to another. So Northwestern Immediate Care has fee for service. Depends on what kind of insurance they have, but it may dribble down to the patient to be a copay, or if they're self-pay, $250 for a visit. That's going to exclude some people and not be painful for others. The FQHCs have a prospective payment system. They explained to me what that really means. That means they have, for that visit hour or that half hour or 10-minute or whatever visit, they have a set amount of money for each visit, and they have to decide how to spend it. Downstream effect of that is they don't have a lot of rapid tests. They use Centaur criteria, clinical criteria to decide whether somebody has strep or not. They look in the throat, they feel the neck, they ask about cough. These are the things that they do. They don't have a rapid strep test. So what are the downstream implications about these disparities? Just structural things about their healthcare setting. The immediate care might end up doing doctor shopping. A patient might go to one immediate care and say, oh, I didn't get my antibiotics. They might sign up the next day and get their antibiotics from a different provider, right? It's non-continuity care, right? And the provider's desire to please patients is they're getting pressure to please patients, and they're measured for every patient visit. They can get blasted for a bad interaction with a patient, and that's in their mind. That's the message they get from above, from between their ears, right? Okay. What about the FQHCs? They have lack of point of care testing, which can lead to overprescribing or perhaps underprescribing. Reduced availability of visits can result in overprescribing or underprescribing or care delay. So you can see inherent in the structure of these healthcare systems, there'll be some disparities, and some can be harmful. So lessons learned. First, curriculum resources are readily available. There's a lot of them. There's the AHRQ toolkit, which I found particularly helpful. There's YouTube that you can Google anything and find a helpful skit or something to make people laugh. There's the CDC antibiotic awareness. Second thing, for our Team of Champions, allowing time for sharing is really critical, so that you can really elicit what's going on, what people are experiencing, and so that the champions can be validated in their work. The champion's job is really to engage at all three major stakeholders: the leadership, the prescribers, and the patients and families. And finally, a stewardship champion can really bring their own talents, their enthusiasm, and their critical insights to outpatient stewardship. And this can be the secret ingredient.
Very nice. Seems knowledgeable, but more conservative than I'd like. If I go to urgent care, it's because I need intervention that is beyond what I can do at home. I can Google remedies, but I need antibiotics. Oh, hate leaving empty-handed while feeling miserable. My name is Katherine Ritter. I'm an urgent care physician with Northwestern Medicine. I am very excited to be here with you all today. I've been waiting a month for this. I have been charged with the daunting task of condensing over 20 hours of content into less than 20 minutes. But hope springs eternal, and I am an optimist, so let's go. If you are sitting here in this room with me today, it is likely that at some point or another in your career, you have felt the squeeze of an antibiotic seeker and the subsequent pressure to give in. Most of us find ourselves under tremendous stress to move quickly and satisfy patients, and antibiotic stewardship sort of falls somewhere by the wayside, right? I love this slide. I call it Happy Penny. Allow with me to share. I would like to share with you all the crazy tale of how I got involved with the antibiotic stewardship movement, how I came to find myself speaking in front of all you fine people here today. When I did primary care, I would frequently hear some variation of the following dialogue. Well, I know little Timmy needs an antibiotic because he has a history of ear infections. He always gets better on his antibiotic, and I just know he won't improve without one. Or, little Timmy doesn't get pain with his ear infections. Last time, I didn't even know he had an ear infection until the provider looked in his ears and said, "Oh my, these are very red." I felt so guilty as a parent. I swore I'd never let that happen to him again. He's acting the same way today. That's how I know he needs his antibiotic. And the kid's smiling, saying, "Yay, I love the taste of that yummy bubblegum medicine." True story. So I'd look in the ears would be fine. But the parents would insist on antibiotics and accuse me of trying to harm their child if I dared withhold the proper treatment of antibiotics. So my first reaction was anger, right? Then I calmed down a little and started to get curious. Who is it that keeps giving you these antibiotics? Because I am your primary care doctor and I know it's not me. Then I found out it was the urgent cares. So 3 years later, I moved to Chicago to be closer to my family. I accepted a job in an urgent care, and that was when I really started to understand the issue. Number one, there is no established relationship with the patient in urgent care. Lack of continuity can equal more defensive medicine. Antibiotic prescribing consequences can seem disproportionate, meaning the consequence of possibly missing a bacterial infection and not prescribing an antibiotic far outweighs the consequence of writing an antibiotic for a viral infection. Okay. Number two, success was defined by speed, how fast could I move, and patient satisfaction. How likely were patients to recommend me to their family and friends? Then there were the true antibiotic bullies, the people who basically viewed their visit to me as a simple business transaction, meaning they paid their copay. Now they expected whatever antibiotic they wanted, even if it was the wrong one. They were not interested in opinions or suggestions or guidelines or best practice recommendations. They just wanted their Z-Pack with the refills. This is true, you guys, you feel me. This is particularly challenging in the virtual world, such as telemedicine or video visits. I wanted so desperately to be successful in my new job. I wrote for a lot of unnecessary antibiotics in the beginning. My guts churned every time I did it. I knew I was reinforcing the false belief that every sniffle needed an antibiotic, but at that time I honestly felt trapped. I could not see a way out. I used to lie awake at night in tears and wonder if I had made the right decision. Now, fast forward a few years. Once a month, all the immediate care centers, which we call ICCs, would get together. We'd order dinner, we'd play games, we'd talk about clinic updates, etc. It was good times. One night, there was a guest speaker from quality control named Dharmesh Patel, who unfortunately is not here with us today, and he was talking about antibiotic stewardship. And I was like, what? What's this? So I went up to him after the meeting. I introduced myself and I demanded to know who he was and what he was about. That is all true. The rest, as they say, is history. That was the day I found out antibiotic stewardship was a real thing, as in it really existed, it had a proper name, and it was important. It wasn't just something you learned about in school, saw on paper, and then promptly forgot all about it when you were in the clinic or when you're feeling the squeeze of a bully. And I learned that there were other people who felt the same way I did, that antibiotics were not always being prescribed appropriately, and we wanted to know what could be done about it. So I joined the Antibiotic Stewardship Movement, formerly known as the ADSP, Antimicrobial and Diagnostic Stewardship Program, informally as the ABX Stew Crew. I started speaking at our monthly ICC provider meetings. Darmesh and I came up with this great idea to create comedy skits featuring a character named Miss Penicillin, professional antibiotic seeker, played by yours truly, and each performance would showcase some aspect of stewardship. It has been 2 years now, and the penicillin campaign to promote antibiotic stewardship awareness has blossomed into an unbelievable success story beyond anything Darmesh and I could have ever imagined. Our skits have featured techs, nurses, management, and even specialists as guest speakers. Doctors in other departments have used pictures of Penny in their system-wide presentations. Managers have name-dropped Penny when it was time for their annual review and they wanted to mention all the good things to come out of the ICCs. Providers were tuning into the meetings specifically to see Penny's antics. Even their children would wake up at 7 in the morning to watch the penicillin skits, and we'd all just laugh and laugh and laugh. Penny sang songs and made music videos and is presently on tour of all the ICC regions, delivering cookies and cupcakes. It has been such a joy to create this character and so much fun to get to act and sing and travel throughout all the regions, spreading the message of antibiotic stewardship awareness and hope that if you too feel trapped by antibiotic bullies, there is a way out. At the same time, the ADSP has been busy distributing sinusitis education posters, creating easy access tip sheets, and improving prescribing policies by updating local pharmacy formularies. And all of this is making a huge difference in our immediate care culture. For me, the most effective way to communicate with management is to publicly include them in the penicillin comedy skits, as we may or may not do today, and to privately remind them that having an antibiotic stewardship program is actually a JCO requirement to receive federal Medicare funding. And I found the best way to get the attention of and communicate with providers is just to make them laugh. So here's a harsh truth. Sometimes I'm afraid that I'm annoying my managers. Doc Sutton so graciously calls it nudging, because practicing good stewardship means being okay with not being liked by everyone and not necessarily satisfying every patient every time. Gasp. For this reason, I am very grateful that my hospital has given me a platform to speak out about this super important topic. Let's be honest, I'm pretty sure I'm eating into profits and making life harder for my poor practice managers who have to deal with all the complaints. Oh, Ritter didn't give me my Z-Pack. But you know what? My management continues to support me. So my challenge question for you is, would your administration encourage you in the same way? And if not, might you feel comfortable gently reminding your admin that providing the space and basic resources to create an antibiotic stewardship committee is actually a JCO requirement to receive federal Medicare funding? I'll just leave that there. Next slide. Okay, this slide is a summary of everything we have discussed up to this point. In conclusion, my greatest gift from the ADSP has been finding a healthy, adaptive way to sublimate the frustration I felt, and sometimes still do, against unreasonable antibiotic seekers and also against myself when I give in. Taking on a leadership role in the movement has given me a safe space to vent, to cry, to seek guidance, and to learn new strategies from highly intelligent people. I try to apply the advice they give to my antibiotic practices and to other aspects of my life as well. And all of this has legitimately made me a better person. Finding my tribe has validated my feelings and plucked me from my sense of isolation. Some days it's a real struggle to find that happy balance between speed, patient satisfaction, and antibiotic stewardship. That is an understatement. But you guys, we have to try. The World Health Organization estimates that by the year 2050, Antibiotic resistance will cause more death than heart disease or cancer. Joining the NM-ABX Stew Crew has empowered me with the knowledge that the good I do today will outlive me when I am gone. And we all get this chance to make the world a better place for future generations. Won't you join us as we pave this path to a safer, healthier tomorrow? I promise you, the beauty is in the journey, and you can start right now with whatever you have, wherever you are. This is a photo of Penny bringing treats to the North region. There has been no shortage of calories on this grand adventure. Aha, now, this is the link to Penicillin's official music video. This is truly the pride and joy of my entire penicillin career. You can find this video on YouTube under the Jim Yankee channel, that's my PA, or on Northwestern Medicine's ADSP educational videos page. The lyrics are all real things that patients have said to me when they were begging for their antibiotics. It wasn't hard, it wrote itself. Things have been said to me. So I'd like to end on this photo of my beloved Stew Crew from last year's summit. Big bunch of goofballs. I thank you all for your attention. The honor and privilege has truly been mine. Next up, I would like to request a little audience participation as Dr. Sutton presents the 2021 Mayo Clinical Proceedings article entitled, "I Never Get Better Without an Antibiotic," by authors Simzak, Keller, and Linder. We really like that, Linder. It's one of ours. By the way, I brought 6 copies of the article right there at the end of the projector. If you were to access this online for 24 hours, you would have to pay $31. No joke. I looked at it last night. So it's my gift to you all. Saving me $30. But yeah, it's a good article. I'll make more if you need. Now, may I please have a victim? A volunteer. I promise it won't hurt much. Pain is subjective, right? Here's a brave soul. Come up, miss.
Thank you. Will you be loud?
Yes.
Okay. So this article highlights 5 of the most common patient appeals for unnecessary antibiotics and how providers can respond in thoughtful, constructive ways. So first, we're going to list the 5 common appeals. My regular doctor would have given me antibiotics. Number 2, this happens every year, and I don't get better without antibiotics because I know my body. I've gotten that one. Number 3, I've gotten this one too. I'm going on vacation tomorrow and I can't get anyone sick. Number 4, everyone at the office has the same sickness and they're all on antibiotics. Therefore, I need an antibiotic too. Number 5, I took the morning off work and I paid my copay and now you won't give me anything? To help me present the key prescriber responses extracted from the article, please welcome
Rashida Shah from Lake Forest.
From Northwestern Medicine.
Yes.
That's right. Great. Okay.
Thanks for choosing me to be your guest speaker, Dr. Sutton. I love public speaking and totally want to be doing this.
Example number 1.
Well, my primary care doctor always gives me an antibiotic when I have symptoms like this.
Well, while it is helpful to know that you've been treated like this in the past, I'm focused on how you're feeling today. Also, there's been more recognition lately about the harms of antibiotics. All physicians are being urged to use antibiotics only when they are more likely to help than hurt. Okay. Example number 2.
When I've been sick like this in the past, antibiotics were the only thing that worked.
You have a cold virus and antibiotics won't help. What you experienced in the past was the natural resolution of your illness. Your body has an amazing capacity to heal itself. Also, we want to avoid putting a chemical in your body that cannot help but could hurt you. Example number 3.
I'm going on vacation tomorrow. Can't you give me something just in case?
Unfortunately, antibiotics won't help you get better faster, and they can't cause problems like diarrhea that could ruin your vacation. There are some effective things you can do to manage your symptoms, including staying hydrated, taking ibuprofen, and using saline nasal spray. Example number 4.
Something is going around in my office and everyone is sick. Many of my colleagues have been given an antibiotic for this and seem to be getting better, so I think I need one too.
My chief concern is your well-being, since you are my patient and I will treat you as an individual. My examination shows that you have a viral cold. The fact that your colleagues are sick makes it all the more likely that it's a virus that's spread around, and antibiotics don't fight viruses. Finally, example number 5.
But I took a whole morning off of work to come here. Are you telling me there's really nothing you can give me?
I am so glad you came in to see me today so I could evaluate these uncomfortable symptoms that you're experiencing to make sure it's not dangerous. You are sick with a virus. While we can't make the virus go away faster, you can feel better sooner by supporting your body with rest, lots of fluids, and ibuprofen for your body aches. So in conclusion, the 3 most important messages to convey when responding to all appeals for unnecessary antibiotics are the following. Number 1, convey that the patient's well-being in the moment is your primary concern, and the motivation behind the recommendation against antibiotics is at this time. Number 2, recognize the patient's suffering as real and empathize with the patient about the burdensome impact of illness on daily life. Number 3, affirm the patient's decision to seek medical attention to rule out a more serious illness. Thank you for your attention. And now, please welcome our final speaker of the hour, Miss Penny Sillen.
Good afternoon, summit participants. Today, we have a very special antibiotic stewardship game show edition in which I will quiz the physician manager of my clinic about the ADSP, urinary tract infection and beta-lactam allergy guidelines. Some amazing prizes are at stake, so let us begin. You accept my challenge, physician manager.
Challenge accepted. I'm ready.
Question number 1. Which 3 antibiotics are recommended as first-line drugs for uncomplicated adult cystitis with no additional features?
That's easy. Cephalexin, dextromethorphan, and that.
All right. Plot twist. What if the patient has a penicillin allergy flag because their grandmother said they might have had a rash to penicillin therefore they've never tried it?
I would delabel that penicillin allergy.
I see. And what if the patient's allergy was listed as headache, non-bloody diarrhea, or abdominal bloating?
I would still delabel that allergy, and I'd feel fine about prescribing the cephalosporin.
Oh, that's a bold answer, Doc. Bold and correct. Next question. You want to prescribe cephalexin for a simple UTI, but the patient has a penicillin allergy listed as hives, which occurred more than 10 years ago. Tell me, Doc, would you still write for that cephalexin?
Yes, Penny, I would.
Oh, dang it, she's good. All right, double or nothing for the grand prize. True or false? Smelly or cloudy urine is considered positive for UTI and should always be sent for culture.
False. Don't send a culture unless there are 2 symptoms of pain, bladder irritation, or pyelonephritis.
Dr. Clinic Manager, your medical knowledge regarding UTI treatment, culture, and penicillin allergy is unbeatable. What's your secret to this superiority?
Well, Penny, I've studied the tip sheets from adsp.nm.org, so I can confidently choose the best antibiotic management plan for my patients. All the information I need is right there in easy to read, color-coded chart.
Congratulations, Doc. You scored 100%. It's my great privilege to present you with the highly coveted, prestigious golden hat. Careful, it's still a little wet. From the colored spray paint, of course, and your bonus prize, 3 golden Castile whites.
3?
Yes, 3 properly used Castile wipes can dramatically increase the accuracy of urine testing.
Thank you for this honor, Penny. Wow, it takes me back to when I won my first golden hat at last fall's bug ball competition. Finally, I have a matching pair. You can place one at each end of my mantle. Cherish them always.
Well, you earned it, Doc. Hats off to you, no pun intended. Yes, I remember well the day you bested me at the Bug Bowl. At least I was runner-up and received a consolation prize of Gold's trainer. Dr. Practice Manager, the entire state stands in awe of your UTI antibiotic and allergy academic mastery.
Thank you, Penny. Winning this golden hat award today makes the sacrifices all worth it.
Until next time, this is your antibiotic stewardship team reminding you that when nature calls,
Answer the call. Great, that's right. And then Dr. Damani's here also, and Penny will come back in a minute. Do we have any questions? Yeah, hi.
So this is one of the few presentations which sounded more like, it felt more like a, private conversation one-on-one, but excellent. It's quite good. My question is, yes, people come, they do the copay, and then they're expecting something in return, like antibiotics. So, and you just followed the guidelines and the best practices. How did it impact patient satisfaction?
We're gonna have to wait a moment. And still let it come back out. Yeah, she'll be in a moment. I know that,
I need breast gain.
what she's mentioned is that, that Dr. Ritter, I know, has done some study of this in a study environment and figured out that it really didn't impact patient satisfaction if you do follow that kind of that four-step communication strategy. And part of that is showing empathy up front, showing that you're really paying attention to the story, like giving that physical exam, telling back the story to the patient, saying, oh my gosh, yes, yes, you're tender up here, but your lungs are clear. Your pulses look fine. Okay, all these kind of reinforcing things, and then summarizing by declaring a diagnosis. These are, you have a viral cold that involves your sinuses. You have a cold up here, a head cold, right? And showing that the roadmap and the contingency plan. These are the things that was involved in his study that showed that there wasn't a real drop in patient satisfaction, but there are going to be immediate feedback on satisfaction surveys where people didn't get what they want. So we have to deal with it. And we have to recognize and grow to our managers the understanding that we can't, that if we're going to be doing good medicine, that we may not please each individual patient. We have to do it with ourselves. And what we're trying to do with being a presence and being bigger than ourselves, being that champion, is to help leadership understand that 100% satisfaction isn't going to be good medicine, and we want to be giving good medicine, right? And it is a stewardship, it's a mandate from recognition to be trying to get good medicine. Complicated answer.
Yeah, what about those of us who, are a little knowledgeable, thanks to Dr. Google, and then we come to the clinic and say, it's been going on for like 3 days, and I know it's going to turn into bacteria. How about giving me the antibiotic?
But you must be an outpatient, maybe a care provider. Sound like me.
Dr. Ritter has experience a million times a day with this. One of the things you can extract kind of from that article that we were just talking about is that I'm seeing the patient as you are right now, and I can see that you're in the midst of a cold, and the average cold lasts 7 to 10 days. And most people don't. Most people think they're superhuman, and if they're going to end by the weekend, right? It'll be done. all done, and the antibiotic is the way to get there. And that's just not the natural history of things, right? So,
Anyway, Kathy, what would you say? Yeah.
I love that question. First of all, can I just say that? A lot I want to say. I gotta condense it down. So that's the challenge. That's the $1 million question right there. I need to get people to like me. They get a survey sometimes before they get out to their car. And if I get a 0 on my medallion or whatever, my manager gets a message right then and there, and they have to come talk to me. And sometimes I have to try to make it right with the patient. So
Really,
it's-
before the
yeah,
patient even leaves?
sometimes before they leave. So it's, and can I say this? Am I gonna get in trouble if I say it? It's true though. Part of my pay is actually linked to the satisfaction surveys. So I am highly motivated to get people to somehow like me. But they will come in and say, I've had 2 hours of sinus pressure and I'm any of those that going on vacation, whatever. I just want you to send my Z-Pack to the pharmacy at the corner of this and that. And I'm like, I'm presented with an opportunity. So what I found the most successful things, I hit it straight out the gate. I hit them with love. I mean, I am really sincere. I'm like, I'm sorry. I know you feel miserable. I'm really sorry. You did the right thing by coming in today. Our goal is to figure out, do you have a bacterial infection? If so, you need an antibiotic. You're going to start it today. I will send it right now before you walk out of here. If it's not a bacterial infection, we don't use antibiotics for viruses because they don't work. I have other things that can help you. I will say that within the first 30 seconds of them walking in. We are lucky to have computers in each room. I pull up the tip sheets. So by the time they start saying, well, you know, my sinus is stage 4, I turn the screen around like Vanna White, I touch it, and I'm like, let's discuss. Let's talk about what constitutes bacterial sinusitis versus viral sinusitis. And I always say, I will help you either way. I will help you either way. You did the right thing by coming in. So they get defensive. They're like, well, I came for my antibiotic and now you're not going to give it to me. You enjoy watching me suffer. And it's a tough sell. And sometimes I get it. Sometimes I don't. Sometimes they just come in, they're like, they'll shut me down. They're like, I am here for one reason and one reason alone. I want this antibiotic, and they'll escalate. And another true story, Sutton, you knows about this. I had somebody that threatened to throw a chair at me once because I stuck to my guns. I channeled my inner Linder and I was like, no, this is viral. Let's talk about it. I can help you in other ways. And they were like, no, that's not why I came to you. That's not why I took the afternoon off work and paid my copay. Presented with the dilemma, what do I do? So I just try to get as much as I can. For me, my purpose in being here too is just to spread awareness about it because we all knew it. We all thought it, but nobody ever talked about it. And we sure didn't say, you know, wow, this is linked to my pay. This is linked to, I gotta move quickly. I need them to like me. That is what's really important. Is anybody talking about stewardship? So we're just here trying to have a conversation and grateful to have a seat at the table so we in urgent care settings can talk about it as well. Are you in urgent care or convenient care or primary?
No.
Oh, I'm sure you surprised me.
One last question. Did that in any way increase the time you take with each patient?
So, yes, but I say it 10 to 15 times a day. So I get excited and talk fast. So I can hit it pretty quickly, but it does. And when somebody comes in at 7:29 at night and you've got 10 people in the waiting room, that's a factor. And let's be honest, that is, you know, so much I want to say, so much, and we're running out of time. Yes, it is. I've just learned how to get very efficient, and I can detect faster on whether I have a chance, whether somebody really wants to hear me or whether they just want what they want, and then I'm presented with a dilemma. So.
And some people are going to be reassured, oh, good, I don't need to have antibiotics, and hearing about the side effects, maybe reinforcing those. Oh gosh, you know, the most common reason people go back to the emergency room is any drug side effect is antibiotics, right? Taking antibiotics better be necessary.
Two things that have helped when I say, like, you don't want to put that unnecessary chemical in your body unless you absolutely need to. And the second thing I'll say, you know, I offer it. A lot of people don't want this because they don't need it. They just, you know, they just want to do be natural and
natural.
I tell them that whether or not it's true. But I say a lot of people just they know it's a cold. They just want to fight it naturally. And then the people, the power of suggestion, they're like, yeah, me too. I want to do that too. And I'm like, you can do it. You'll get a survey on your phone. So, yes, ma'am.
We've had, like, when talking to our urgent care, they reference it as a transactional service, like,
Yes,
I'm
ma'am.
coming in and I want. something
Yes,
in
ma'am.
return. And I was like, that was the first time I've ever heard about that, but
Yes, ma'am, it is.
I have a friend in primary care who says that she does write some prescriptions for some decongestants that are prescription and for some benzoate, the pearl, Tessalon pearls or whatever, because it is transactional and they've gotten something a prescription that they otherwise wouldn't have access to.
Yep, it takes a lot of time to explain to somebody why would they paid their money and they're expecting a service and now you're trying not to give it to them and why. Come in, thank you. Dr. Sutton and I are also available afterwards too. I will talk about this all day long, so you guys can find me, I'll talk to you about it. Yes, ma'am.
So I work primary care doctor. What I find out in primary care is I will go through that explanation with patients and explain to them that this is why you don't need it, this is what you can do to treat your symptoms. And then they turn around and go to urgent care and go and get the antibiotics.
Yes, ma'am.
Strategies to prevent that.
All the time.
It's doctor shopping, yeah.
I do virtual and tele visits as well, and I will get a lot of bounce back. I went to the urgent care 2 days ago and they were so mean. They didn't listen to me and they didn't give me my Z-Pack. So, and then they're virtual, they're sitting at home. So now I don't even have vitals. I can't even look inside their eyes, ears. And you've got 5 to 7 minutes to try to explain to them why. Well, that first doctor was right. You have a viral infection. I mean, it's tough. It's communication.
Prevent the doctors. I mean, I know. Do you have any ideas of how that?
What I have found the most success was, to be really honest, I have to have energy all day long because it takes a lot of energy. It takes a lot of time. I say, hey, experts are saying this and this, and I'll email these out to you because everybody's signed up for the My Chart, right? And I have to offer them something else. I can't just take their copay money and not give them anything. So we do a lot of Flonase. I do an unhealthy amount of Tessalon. Sometimes I offer a work note, and I'm like, you need to rest. I do what I can. Sometimes I get it. I've gotten a lot better at it over the past couple of years. But
Kathy, I really like how you preemptively in the moment you're meeting. I understand you have congestion up here in your sinuses, and you're here to decide whether you need antibiotics or not, whether it's bacterial or
I know where
or
this is
not.
going. When they sign up for a virtual visit and it says 2 days of sinus infection, yeah, I know what's up.
Yeah.
So I channel my inner Linder and I take a deep breath and I call it. It's the same dialogue I say every time.
Yeah.
But I mean it. I'm like, you did the right thing by scheduling this. If you have a bacterial infection, you need antibiotics. I put that out there. I'm not shutting you down. It's not like I'm not listening to you. But if you have a viral infection, antibiotics will not help you. My job is to help you figure out which is which. How do we do that? Hey, I've got this tip sheet designed by infectious disease experts. Let's talk about it. And I'll do that before they get too far into telling you what's up. Because I know what's up. You know what's up. And I'll say 10 or more days of progressively worsening sinus symptoms, fevers of 102 or more plus thick drainage for the first 3 to 4 days, or double sickening, you need an antibiotic. You'll get 5 days of twice daily augmented. It's 10 days or less, with low-grade fevers for the first 2 days, 4 days of clear drip, and then thinking chunky on day 5 and then clear. Well, that's a virus. And they're like, whoa, that sounds like me. Okay, that's good. So you don't need antibiotics right now. Let's talk about your Flonase, your Astelin, your coughing. It's always here. You want some Tessalon? Let me get you a work note too. Just kind of divert. I try. It's tough. It's not easy.
Last week, I had the most unusual experience of pulling up one of our own guidelines and taking it to a patient. And I printed it up ahead of time because I knew she was coming up for sinusitis. And we had to decide whether she was bacterial or not. But that was based on your recommendation of pulling down our guidelines, and going through it. That was great.
Somebody please time check me. I do not want to be disrespectful to the next people. And my little time thing is not on.
I think.
So when can I toot our own horn? I had knee surgery, couldn't walk for 6 weeks anyway. So I'm doing virtuals once a week still because of that. And there's a drop down list when people schedule their virtual appointments. And one of those was sinus infection. And I'm like, well, how do you know if you have a sinus? So you have 2 hours of sinus pressure and you check that. And now the expectation is that you'll get your antibiotic and you'll get your Z-Pack, which is the wrong antibiotic anyway. So we were able to successfully get that changed to sinus pressure. So that way the seed is not planted. Oh, you have an infection. Or some people, they'll tell me, they're like, I have an infection. And I'm like, you do. Let's talk about bacterial versus viral infections and how we're going to treat each, because they're treated completely differently. I'm like, yeah. And I'm like, okay. So a game win for us.
Are you our next speaker? No, somebody's coming. Yeah.
Okay.
Yeah.
Yes. Oh, I think.
Just one thing that I wanted you guys to be aware of that I realized recently that scared the crap out of me. Have any of you guys heard of the company Jace Medical?
Yes, I have. Yes, I have heard them. Yes.
So I can call them right now or get online and I can get like a month's worth
A
of
lifetime supply.
azithromycin and whatever else in a nice little teal fanny pack.
Oh, read the comments. The comments are even better.
I know,
Yeah,
I know.
people are
So
like, oh, thank God I
we'll
can
be
get my
aware
life.
of that, that we're doing all of this, and now this is going to our patients, so we have to be aware that there's this nonsense going on out there as well, and we're working in Michigan to try to look at ways that we can find to make it illegal for those companies to practice in our state.
Thank you for doing that. Thank you. I have found that company.
They have some sort of online visit with the provider who's licensed in your state, and they will then have that prescription, and they will send it to you. And there's multiple companies, but Jace is just the one with the cutest fanny pack, so that's right.
Thank you.
Also, in
Thank you.
Chicago, at least the Chicagoland area, there are antibiotics available over the counter brought from other countries.
Yes.
And a
Talk
lot
about
of
that.
my patients are a large Hispanic population. And they will come in and say, well, I took like 3 days of antibiotics. And we're like, where did you get antibiotics from? And they're like, oh, I went down to, the Mexican store, the pharmacy, and they gave it to me. Like, oh, okay, well, let's talk.
Yep. Yes, yes.
I was blown away when we found that through the.
Oh,
Thank you. Thank you so much, everyone. Thank you.
Yeah, that was mind blowing.